Hey everyone, welcome back to another video from Aurora Fire Rescue. Today I am super privileged to be here with Mitch from UCHealth. We're going to be doing a Fleet Friday on Cat 1. Mitch is here to tell us all about that. If you followed along with the channel before, you've probably seen Cat 1 make an appearance in a couple of our videos, and we talked a little bit about what it does, but today we get to go look in the back, and this is one of, what, only like 20 or so units in the
23 in the US, so it's pretty lucky, and this was the longest lasting one, and this was the third in the US, so.
Awesome, well I can't wait to check it out and learn more about it. With all of these, let's start where you work, which is the cab of the rig.
Yep, I'm in the driver's seat over here. So I'm the EMT, and so here we go, we got this. It's pretty standard, just Dodge chassis. We do have some lights in here, an intercom to speak to the back, and then we have a load leveling here, so the truck can go up and down as well. So you can kind of see the back end lower in there, just because the scanner in the back has to be level to do all of that. But pretty much everything else is pretty standard up front here.
And you talked about the need for an intercom. It looks like this cab and chassis are actually separate there. They don't meet up like a lot of
completely separate. So the nice thing is if they're talking too loud back there, I can just turn them all the way down and not have to listen to them. But we normally keep it up, and then you just hit a little red button here and we can talk to them in the back, and they can listen to us and make sure they're all good to go to get driving and everything like that.
Great.
So yeah, it is four-wheel drive, yes. Although it is heavy enough to where I have never needed to use it, even in the snow. It seems to have really good traction in the snow.
Okay, so from here, if we want to walk around and check out what's in the compartments, the side of this ambulance looks different than a lot of the ones that I've seen before. Different compartmentation.
Definitely completely different than the Falcon ambulances. And so in this compartment here, we have our oxygen tank, stair chair, and then a broom. So that's that compartment. In here we have all the fuses for the back and the front.
The inner workings
a
ton of electronics in this rig.
Yep. And it controls everything in the back. And then here's just a quick little fire extinguisher, and then this is where our modem is for internet. And then in here we keep an OB bag, a pediatric bag, a little trauma bag, because we have to be ALS equipped per the state. And then we also have a backup Alaris pump, which we use to give one of our drugs, nicardipine, which is a hypertension drug. And then a couple of cones to try to protect ourselves on scene. But
sure. Up there, folks may have just heard the sound of the air kicking on the mic. I haven't seen a compartment like that on an ambulance either. So what does that do? So
as our air conditioner, try to keep everything super temperature controlled. Our CT tech likes to call it San Diego in there. It's always the same temperature. So yeah, that's we do have that.
And then do you have compartments on the other side of the rig?
We have one in the back here. This one is just for our stretcher, or our a backboard and some other extrication stuff, which we hope to never need or use, but we have to be equipped for that as well.
Okay.
And then over here, we have our generator, which is kind of loud as well, and that keeps the CT machine up and running, and then everything in the back that has really anything in the back, all the lights and the telehealth screen as well. Keeps that all up and running, so that way the truck can be turned off up front, but have everything running in the back for that as well.
And then usually there would be a tall compartment to the right of the door here, but there's not one on this.
There is not, no. So actually behind that compartment here is our CT scanner.
Wow.
So the idea behind this was this CT scanner is from in the ICU, they can bring it kind of mobily, and somebody had the great idea of, hey, let's throw this in the back of an ambulance and see how we can treat strokes that way. And so they did that. So this is we can only fit a head inside of here. It's small enough to, like, you can't even get a neck or anything like that. But so they threw it in the back, and this one's been working ever since we got it. It's the most reliable one, and we have 2 here in Colorado, so we have another mobile stroke unit in the Springs.
Close the door behind us so we can keep it San Diego in here.
Absolutely.
So walk me through, I guess we could just start right there with the CT. Why is there a CT in this ambulance?
The reason behind the CT is so we can identify if somebody's having a stroke in your driveway, right? So you don't have to, we get called out with Aurora Fire and Falck, and if we determine that person is having a stroke, we'll bring them onto our ambulance, we'll get them in the back, we'll scan them immediately, try to get that, just to make sure they're not having a bleed. That's the initial scan. And then we can also do a CTA, which is CT angiogram, which highlights all the vessels in your brain. So if they are having a clot, we can identify where that clot is and then get their correct medication on board. We do have a medication called TNK, or tenecteplase, which that is a clot busting medication. And then with that, we can, if they are having a large vessel occlusion after we give that drug, we can always take them to the most appropriate hospital based off of that, and they can go in and do a thrombectomy on that person.
And is there kind of like a time window on when that's effective or not effective?
There is. So we have to, if we are going to give that medication, it has to be done within 4.5 hours of that person's last known well. And by last known well, I mean the last time somebody saw them completely normal is the last known well. A lot of people get it confused with, oh, well, I came in and they were like this, and then so the last known well was 20 minutes ago, but it was actually 4 hours ago or something like that. So on those time frames where it gets close to 4.5 hours, that's when this truck is really important, because we can go out there, we can give this medication, give that, and then take them to the hospital after that. And sometimes by the time you get to the hospital, they're outside of that window and they can no longer give that.
Sure. One of the other things that you've talked about is we. So you are a part of a crew. You're not just the only person assigned to Cat 1. How many people are usually on this truck, and what do they do?
So we have 4 people on this truck. We have an EMT. I do all the driving and then kind of just making sure on scene, see if anybody needs help with anything. I do IV, stuff like that. We have a paramedic who their role is to go inside the house at first, do their assessment on the patient, while our nurse gathers information from AFR or the family. And then based off of that, they come together, they make a decision of whether we should accept that patient or not. And then if we do accept that patient, we'll bring them on here. The medic will get them hooked up on our monitor, and try to get an IV, and then if anything does happen, if that patient starts to deteriorate, they can kind of step in the role and kind of take lead on that situation. And then we have a nurse who has to be a critical care nurse as well. And this is mainly like her job, her and the CT tech, pretty much their job. We'll bring them on here, we'll do the scans, they'll start the NIH, which is a pretty long assessment that they'll do with a neurologist behind you. There's a screen right behind you there that a neurologist will pop on. They'll do the scan together, and then the neurologist and them will make a decision on whether we should give TNK to that patient or we should just go to the hospital at that point. And then we have a CT tech, which need to have a CT tech for our scanner here.
So I'm one of our CAT scan technologists, so I run the scanner.
So pretty much the most important part of this vehicle.
Ish, yes, kind of, sort of.
So walk me through, if you've got a patient and they're having a stroke, what happens next?
So typically once our patients get in the truck and we enroll them, meaning that we put them actually here in our back of our truck, first thing we're going to do is the non-con head CT. We have to determine which type of stroke we're dealing with, whether an ischemic or hemorrhagic stroke, to be able to properly treat that patient. So first thing we're going to do is get the non-con. We'll send those images to the neurologist that beams in here, as well as to the neuroradiologist back at the hospital to read. And I'm sure that Mitch went over all this here, where we get an EKG, we'll get vitals, we can do IVs, we can run their blood work to check their creatinine, check their PT-INR, to check their clotting factors, as well as doing the NIH stroke scale. Now, where the injector comes into play is if we think this person is having a large vessel occlusion, meaning one of the large vessels within the brain that's occluded, that there we'll do the CT angiogram. So I'll give them an IV contrast. It helps to highlight all the blood vessels in the brain. And if you can see where that clot is located, then that just expedites the amount of time to get the patient to interventional radiology, where they can do the thrombectomy.
And what is that procedure?
So the thrombectomy is where they run a catheter either through the groin or through the wrist up to the actual clot, and they can mechanically remove it that way.
Wow.
Yep.
And you mentioned basically two different paths that you could go down if a person is having stroke symptoms. So really, are there just two major kinds of strokes overall that you're looking for?
Yep. The majority of strokes are ischemic. That accounts for about 85%, meaning that there's a occlusion in the blood vessel that's prohibiting the brain from getting blood flow. The other that accounts for the other 15% is a hemorrhagic, meaning that a blood vessel has ruptured and is just bleeding into the brain. So obviously you don't want to give a thrombolytic or a very powerful blood thinner to a patient who has a hemorrhagic stroke, which is why we have to do the non-con head CT first. So this is our power injector. What that will do is that we can set how much volume we want to give the patient, as well as the rate, how fast we want to give it to them. So typically in the hospitals, we're going to use these to give much faster and a little bit lower dose than what we're doing here. Mainly, our scanner is very slow in comparison to the hospital. It works great for our purposes here on the back of a truck, but it's obviously much smaller than your typical CAT scan that you see in the department. So we give a little more volume because it is a little slower, and we don't have to give it as fast because our scanner is so much slower. So typically with these, if one of the medications that we carry on our truck is nicardipine, and that runs through a drip. So depending upon which hospital we're taking our patients to, we'll determine which pump we're going to set up. If these patients have a very high blood pressure, we can start putting them on a cardine drip and start bringing that blood pressure down.
Okay. So that's the purpose of those, is for blood pressure issues.
Correct.
Where do you watch as the CT tech the results of what's coming through the CT itself?
So this laptop is technically my control panel. With this particular scanner, there's a tray over on this door. So what we'll do is we go ahead and we clear everybody off the truck for radiation safety purposes, but then I scan from right down there. Okay. So then as the images are coming up, they present on my laptop, and then from there I can send those images via Wi-Fi to the PAC system back at the hospital.
Wow, so that's incredible.
I tell everybody, I've been doing CT forever. Never scanned somebody in their driveway. Never thought we'd have the ability to do that, let alone do a CT angiogram.
Yeah.
It's pretty crazy.
And have you seen positive outcomes because of this?
Absolutely. We were part of a nationwide study when we first started to basically prove what we already know. Time is brain. The faster you get treatment, the better your long-term outcomes, that kind of thing. And per the study, we were treating patients much faster than EMS, and we were shaving off about 40 minutes compared our MSTU times to standard EMS times.
Wow, incredible.
Yeah. And at 2 million brain cells a minute, that's a lot of brain saved.
And so that's the 4 people that are on the truck. And then behind you, we have a telehealth screen for the neurologist to pop onto. So once we get on scene, we'll call our neurologist. They'll come on screen and they will go out over everything with us. We do have a regular monitor, same thing that all of Aurora uses. So we're pretty familiar with that. Suction, and then we have a whole bunch of just general things that we'll use here. We have a intubation bag here, and then over here the CT tech has their contrast in here, contrast tubing, and then we have a couple backups. We have a translator here, and then some extra paperwork if we need that. We have a refrigerator down here that we also have to keep, and that has our Pepsids in it. We have creatinine and PT Plus to check kidney function and INR on patients, so we can either give them TNK or Belvaxar. And then on this wall here, we have all of our criteria for all of our dosing for TNK. That's a big one that we the nurse and medic both have to go over and agree upon before we give that medication. Our exclusion criteria, our inclusion criteria for bringing patients on board with us. And then if we're doing a rendezvous as well, we have that transfer sheet there. We also have a injector, so we can do a CTA angiogram, and that is all the CT stuff. I don't understand exactly how it all works, but that's for the CT tech to use.
And then earlier you mentioned the screen that was behind me, so that's it. Who do you call on that screen, and what exactly are they doing?
So we call a neurologist on that screen. A neurologist will come on, and we have a speaker and microphone right here as well. So the stretcher will be up a little higher normally when we have a patient on here. And that way the neurologist can talk directly to the patient, and then the neurologist will go through the NIH with our nurse as well, and go through that whole process with her, and then kind of determine a treatment plan that we want to do for that patient, and where the most appropriate hospital is, and how we're going to get there and everything like that. And then we'll bring the scanner forward and then scan backwards on their head.
So here on the floor you can see wheels and a track system.
Correct.
So that's adjustable to pretty far back.
Yep. And then so it'll come out to about here. You'll have the donut right here on them, and then they'll scan backwards. That was for installation, so they could get the scanner in here and get it all set up correctly. And then the big thing with the scanner is it has to be level. So sometimes we'll park a couple 100 feet away, or from the house, or from where AFR and Falc are, just so we can get level. And so it can only be a couple of degrees front and back, and it can't really be side to side very much either. So
sure,
that's a big part. It's our iStat, and kind of like what we saw in the fridge over there, we can insert those cartridges in there with a sample of the patient's blood and check their creatinine and INR right from this, and it only takes about 45 seconds. So creatinine is for kidney function, and then INR is determining how fast your blood will clot. So if those two are within range, then we can always give that medication TNK or Valfaxar.
Mitch, thank you so much for showing me and our audience around Cat 1. I can't even begin to say how cool this is as a person who's new to the city of Aurora, being able to see a mobile stroke treatment unit responding to emergency 911 calls, arriving so quickly, and having a CT scanner in the back. Truly incredible. There's obviously only so much that we can talk about on one of these videos, and you might have a bunch more questions about this rig. If they do, where can they reach you or reach UCHealth to see that?
You can either go online to UCHealth's website and look up the mobile stroke unit from there, or if you just Google a UCHealth mobile stroke unit, you'll find a little bit more information about our truck as well as the Colorado Springs truck.
Awesome. Well, again, thank you so much, and thank you to our audience. This was one of our video suggestions. So if you'd like to see something that you haven't seen yet, let us know by sending us an email at afdpio@auroragov.org, or you can send us a direct message on our social media accounts, and I'll see you in the next video.